And I want to thank you for attending this afternoon's webinar, where we'll be talking about our new interRAI assessment tool for nursing facility level of care. And in particular, we'll be talking about the short form version of that assessment, which is the version that will be used primarily by hospital discharge planners who are seeking to admit a Medicaid recipient to a nursing facility. So that will kind of set the stage for what we're going to do today. I'm also joined by another presenter, Roxanne Brooks with Relias Learning is on the phone, and she's actually going to cover most of what's involved with the assessment, but I want to talk to you a little bit first just about nursing facility level of care and what that means in Indiana. So when we say nursing facility level of care, that's the functional standard that we use that allows Medicaid to reimburse us for nursing facility level services for an individual. So it's that standard of functional impairment that an individual needs to meet in order to qualify them for placement in a nursing facility that can be reimbursed by Medicaid. Our standard in Indiana is not changing. We aren't shifting anything. We aren't changing any statutes around level of care or any rules or anything like that. We're just changing the assessment tool by which we collect the information. Some of you may be familiar with our current assessment tool, which is called the eligibility screen or the e-screen. It's not something you would normally complete as hospital discharge planners. And I am going to just kind of make the assumption that I'm talking to all hospital discharge planners today. I realize we may have some area agency folks or nursing facility folks on the phone too, but this is really very directed to our hospital partners today. So you may not be used to dealing with the eligibility screen, but now in the new Pass-R world, part of the way that will facilitate efficient and effective admissions to nursing facilities for Medicaid recipients is having you as the discharge planner or whoever else is working in the hospital and helping with that process to enter some of the assessment information so that the clinical reviewers at Ascend can then make a decision about the level of care of that individual, whether they should be admitted to the nursing facility and whether that should be for a long-term stay or a short-term stay based on changing condition. So we're going to talk just a little bit about what our definition of nursing facility level of care is, and again, knowing that that's not changing. It's just the tool. So in Indiana, an individual is said to have nursing facility level of care if they have either a skilled medical need of some kind, and there's a list of them. You either have some kind of skilled medical need, or you have impairments in performing 3 or more activities of daily living as a result of a medical condition. And that's as opposed to some mental health or intellectual disability condition that might be impacting your ability to perform activities of daily living, but to count towards nursing facility level of care, it has to result from a medical condition. So that is, in the shortest, most simplest form, that is what nursing facility level of care is in Indiana. When we talk about activities of daily living, we use an expanded list of those that's much more inclusive and encompassing of other impairments that a person might have than what are really the federally designated ADLs. That's a shorter list of 5 or 6 things like bathing and dressing and ambulation and transfers. Our list includes some other items that we list some of them there, but it's assistance with medication. It might be a need for 24/7 supervision due to dementia, assistance with oxygen, passive range of motion needs. So we have some additional items that we include as well as what you might clinically think of as activities of daily living. So when we talk about a skilled need, basically that list is any activity that the individual would require assistance on that in the absence of their primary informal support, so in the absence of that family member that might do it for them, it would require a nursing level of assistance. It couldn't be an unskilled attendant care worker or even a home health aide. It would require a nurse to perform that function. So these are things like interventions for a seizure disorder, a person who has an unstable medical condition that really needs the presence of a nurse to assess what's going on with them at any moment, intravenous medications, acute rehabilitative therapies. Again, not therapies associated with intellectual disabilities where people are trying to gain skills that they never had, but these are rehabilitative therapies where an individual who has perhaps had a stroke is seeking to regain a skill that they had previously. By definition, and we'll hit this later, but that acute is a nice keyword that you're probably not looking at a long-term level of care situation. It's short-term. When that acute need is over, they're likely not to have nursing facility level of care. Treatment for stage 3 and stage 4 decubitus ulcers would also be something that would require nursing intervention. Again, there's a list of these, and you're going to see them kind of develop as we go through the assessment tool. So I think I am about ready to hand this over to Roxanne. We have outlined here kind of the sections of the interRAI tool, and we do skip some letters of the alphabet there, you'll see. And again, this is the short form. So what we've done is taken the more comprehensive assessment tool, and we've mapped the elements of it to our current eligibility tool, and then reduce the questions that you need to complete to just those that are needed in order to make a nursing facility level of care determination. So I'm hopefully Roxanne is going to be able to talk, and you'll be able to hear her on the phone, and I'll transfer this over to her. And I do see a couple questions about will the presentation be available, and yes, it will be. We will post the presentation as well as at least one version of the recorded webinar on both our website and the Ascend website. Will be available to you shortly within a few days of the first presentation. I also saw some questions about, sorry Roxanne, I saw some questions about people who had colleagues who were unable to log on because we're apparently at capacity. We have about 125 people on the line currently. We are repeating this webinar on 2 other dates, and we'll share those with you at the end of the presentation. It is, sorry, I got the wrong date. We'll give them to you at the end of the presentation. They're on the slide. But there's 2 other dates. We'll do this same webinar to allow people to have another opportunity. We'll also be taking your questions from the chat. We'll answer what we can today, and then we'll post FAQ updates afterwards. The other 2 webinars are Monday, June 13th from 1 to 3, and Thursday, June 16th from 10 to noon. So if anybody was not able to get on today, be sure they hear about those dates. And we will also try to make sure that we're in a different webinar room next week where we'll have more lines available to us so we can get more people on. Okay, so Roxanne, can you speak now?
I can. Can you hear me?
I can hear you.
Oh, great. I hope everyone else can too. So I just want to take just 1 second to say I'm so happy that I'm able to join you today with your initial training for the interRAI pieces of your assessment that you're going to use in Indiana. I've been in the interRAI world for many, many years, so I'm always excited when I get a new group that I can share my knowledge with and hopefully answer any questions you may have once you type them in, and we will get back to you on them. So I'm going to start first with section C1, and this is cognitive skills for daily decision making. What Debbie did mention is, of course, you did see all of the sections that you're going to be asking questions on, and you may only have 1 question out of that section, which could be quite large for those who are going to be doing the full assessment in the community. For section C here, we're just looking at 1 question, and it's cognitive skills for daily decision making. Up here on the screen, you can look at how we code this, but I'm going to give you a little bit more information so you understand more about what it is you're looking at for this question. This question records the person's actual performance in making everyday decisions about tasks or activities of daily living. And these items are important because it helps with further assessment and care planning, in that they can alert you, the assessor, to a mismatch between a person's actual ability to do daily tasks and their current level of performance, as family oftentimes will be fostering that person's dependence. Some of the examples of decision-making can include choosing items of clothing, knowing when to eat meals, knowing and using space in the home appropriately, or if they're in hospital, of course, using it within hospital, making appropriate decisions concerning how and when they go out of the home, and acknowledging the need for use of a walker or other assistive devices that they need, and actually using those items. And I have to stress that the important thing to capture with this question really is to determine if the person is actively making decisions about how to manage these tasks of daily living, because the intent is to record what they're actually doing. It is not to capture what you believe the person is capable of. And I can tell you this is always a very difficult thing to do. I was an assessor once with the home care tool, and it was always a difficult thing because you think about, oh yeah, they could do this if the family didn't help, if this wasn't in place, they were more than capable. And that's great. You'll have the opportunity to address that. But when you're actually looking at this question, you want to just look at what they're actually doing. So coding for this item, as you can see on the screen, is independent. When you're coding for independent, this person would be consistent and they would have reasonable and safe decisions. Modified independence looks at some difficulty that a person would have in a new situation only. So maybe they're used to a certain routine. That routine is interrupted, so it takes them a little while to sort of understand how to do that and then get back on track. Minimally impaired. In specific recurring situations, decisions can be poor and unsafe. And an example of this would be the person forgets to turn off the stove after preparing a meal. So cues and supervision would be required at that specific time. So every time they cook, someone should, would tell them, please remember to turn off the stove. Moderately impaired, decisions are consistent and poor. I hear a lot of laughing in the background.
If you could check and be sure that your phones are muted again, please. Thank you.
Thanks. Moderately impaired, decisions are consistently unsafe or poor, and cues and supervision are required at all times. Severely impaired, this is when the person never or rarely makes decisions, and this includes when family members take the decision-making away on behalf of the person, regardless of the person's ability to do it. So again, this is where if somebody is actually capable of making decisions, but they are not doing it, someone is doing it on their behalf, they would be considered severely impaired. And then my favorite code, no discernible consciousness or coma. Not quite sure why you would be assessing someone in a coma, but it is something that you can put if that is the case. And I wonder with our interRAI researchers, their motivation behind this. I'm not quite sure yet, but it is a valid code that you can certainly put in. Section D, there's actually two questions that you're going to be asking here. D1 is the first one, and this is making self-understood. Here you would document the individual's ability to express or communicate their requests, their needs, their opinions, and urgent problems, and to engage in social conversation. And when we're talking about communication here, it can take many forms, such as speech, writing, sign language, or a combination of all of these, and can also include the use of a keyboard or a bliss board or a word board. So all of these need to be taken into consideration. Also, a very important point is that this item is not intended to address differences in language understanding, such as only speaking in a language not familiar to the assessor. And an example of that would be if the person speaks in sign language and you, as the assessor, don't understand them, it doesn't mean that the person is unable to make themselves understood. You probably would understand them if you use sign language. So if that's the case, whether it's sign language or a different verbal language, the use of an interpreter is important to use when you're assessing for this item and the next. Coding for the item, as you can see up on the screen, understood. The person can express their ideas clearly and without difficulty. Usually understood. The person has difficulty finding the right words or finishing thoughts, but if given enough time, they require little or no prompting. An example of that could be someone who may have suffered a stroke or a head injury, and they're just having a little bit of difficulty as a result of that. Often understood, the person has difficulty finding words or finishing thoughts, and prompting is usually required in this case. Where sometimes understood, the person has limited ability, but they're able to express their concrete requests regarding their basic needs. So that would include food, drink, sleep, toileting, those types of things. And then rarely or never understood. At best, this is limited to interpretation of highly individual person-specific sounds or body language. So an example of this is that the caregiver has learned to interpret the person indicating pain or their need to use the toilet. D2, this looks at the ability for the person to understand others, comprehension. And for this one, you're going to document the person's ability to comprehend verbal information, whether it's communicated to the person orally, in writing, through sign language or Braille. And this measures the person's ability not only to hear the message, but also to process and understand the language. And again, as in the former question on expression, differences in language understanding are not captured here. Please use an interpreter if you need one. Coding of the items on the screen here, understand, so they can clearly comprehend the speaker's message, and they can demonstrate comprehension through their words or their actions. Usually understands. With little or no prompting, the person may miss some part or some intent of the message, but they comprehend most of it. And when you're looking at this question here, it could be directly related to problems with hearing. So it's important that the ability to hear is established before you start looking at questions on comprehension. Often understood, the person misses some or part of the message, but with prompting they will understand the conversation. Sometimes understands. Person will demonstrate frequent difficulties integrating information and responds only to simple and direct questions or direction. This could be related to cognition, intellectual disability, those types of things. Keep that in mind when you're assessing for this item. Rarely or never understands. For this one, the person demonstrates very limited ability to understand communication, or the assessor cannot determine if the person understands based on their verbal or nonverbal responses. So the next section here would be section G1, and this one is focused specifically on managing medication. And it really is, managing medication is considered an instrumental activity of daily living, or an IADL, and it examines area of function most commonly associated with independent living. So with this question here, you're sort of coding it on two categories, performance and capacity. So performance looks at what the person actually did for themselves and how others assisted them in their IADL. And capacity looks at whether the person can perform the task even if they didn't during your assessment period. And with interRAI questions, usually the assessment period is 3 days. That is most commonly found throughout most of the items that you're going to ask. There are some others where maybe a 90-day window or 14 days, but in most cases you're just looking at a 3-day window. So sometimes that action hasn't happened within 3 days. But if it has, you would code accordingly. So as I mentioned, managing medications is what you're looking at here. And this is the person's ability to remember, to take their medications, open bottles, taking the correct dose, that type of thing. And sometimes what we see with IADLs is because of a lack of skill or experience, a person may not perform some of the activities, but would be capable of doing so with proper training or opportunity. So as a result, it's important to determine if the person is not performing the task because of health problems or because of non-related health problems. And what does that mean? Well, I'll give you an example here. Managing medication. You're assessing a person and they're capable of managing medications at home. So when they were at home, they were able to do this. They knew what medications to take, how many, what they're for, and when. However, they are in hospital, and hospital meds oftentimes are managed by all patients by hospital staff. So the person really is only required to take the medications when dispensed. When the person is assessed if they performed medication management tasks over the last 3 days, very likely they would not be considered independent. They may even be considered dependent in that performance aspect of medication management because they're not taking on any of it. They're just taking the medication. This is an example of a non-health related problem. Hospital staff takes on the performance aspects of med management. However, if you were to assess the person's capacity to perform med management, so if they weren't in the hospital and the nurses weren't doing it, they would likely be independent because they were independent prior to coming to hospital. If they've had no cognitive issues, if the medication has not become difficult for them to manage intellectually, they probably would do very well. So this is why you're capturing both performance and capacity. An example of a health-related problem for non-performance of med management could be functional impairment. Maybe the person has arthritis, they're at home, they can't open bottles, or their pill box, or can't even use a blister pack without help, or there may be some cognitive decline. That would be a factor in determining their ability to know what to take and when to take their medications. So just to reiterate, because the person can be more than capable at the task but do not perform them, both categories must be captured. And it is not unusual for a person to present very differently on performance than they do on capacity. Measuring capacity is a judgment call based on just what you see, what the person's telling you, what caregivers are telling you, and on their presumed ability to carry out the activity. So use everything that you have available to you to make that determination on capacity. As you can see up on the screen, coding for these items, there are quite a few that you're going to be capturing here. Independent, there's no help, setup, or supervision needed for this person to manage their medication. Setup help, this one here, they need maybe somebody just to put the medication within easy reach for them to take. If it's, if they're unable to get to the medication, that could be an example. Supervision is somebody who's providing oversight or cueing, so kind of guides them a little bit as to what to take, when to take it. Limited assistance, sometimes that person on some occasions may need help. Extensive assistance, every single time they're doing medication management, they need help throughout the task, but they do at least 50% of it on their own. Maximal assistance, help is required again throughout the task, so every time they're taking their medications, they need help, and they perform less than 50% of all the tasks. Total dependence, full performance of the activity is done by someone else during the entire period, so within that 3-day window that you're looking at, and activity did not occur. So this is during the last 3 days. And of course, when you're scoring capacity, you're making a judgment call on if they could do it. So you can't use this code, but for performance, you most certainly would. G2 looks at functional status for ADLs, and those are activities of daily living, which examines activities performed on a daily basis and what the person did for him or herself and how others assisted in those activities. So whereas the IADL, so that medication management question, looks at performance and capacity, ADLs only look at self-performance. And we've got a lot of different codes, as you can see up here, that we can use for this particular question. So this section here is by far the most challenging. It's the largest section that you're going to be capturing for interRAI items. And there's quite a few items that are within this section and different levels of assistance that can be required by a client. So as you can see here, we have independent, so there's no physical assistance setup or supervision at any time in the 3 days that you're assessing for these different items. They're independent, and they just need some setup help. So the article or device provided or placed within reach. There's no physical assistance or any supervision during any time within the 3-day window. Supervision, again, is oversight and cueing, same as in the IADL. Limited assistance looks at guided maneuvering of limbs and physical guidance without taking weight. And examples of that would be buttoning and tucking in shirts, fastening belts, those types of things. So you're providing some physical assistance, but you're not taking on any weight as it's happening. Extensive assistance looks at weight bearing. For this one here, weight bearing support, and it includes lifting of limbs by one person, where the person still performs at least 50% of the task. So maybe they need help lifting their arms to get it into the shirt, but once their arms are in the sleeves of the shirt, they're able to button it up, they're able to tuck in their pants, those types of things. So that would be extensive assistance. Maximal assistance, again, weight bearing is provided by a helper, and this includes lifting of limbs by 2 or more helpers, or weight bearing support by one person, and that one helper is performing more than 50% of the tasks. So again, you're helping that person put their arm in the sleeve of their shirt, but you're also providing additional help. Maybe you're buttoning it up, but they can tuck it in. So you really have to look at sort of all the tasks, subtasks that are involved with dressing your upper body, as an example, and how much is being done by the person, how much is being done by the helper, and if weight bearing is involved in the task. Total dependence, that's full performance of the activity by others during the last 3 days. So every time a shirt has to go on, somebody else is helping that person put that on every single time. And then 8, the activity did not occur. So if they didn't get dressed in the last 3 days, activity did not occur during that entire period. So there's quite a few things to be looking at with this section. Here are the items that you're going to be looking at for ADLs. Bathing is the first one here. So you want to look at how the person takes a full body bath or shower, and this includes sponge baths. And it also includes how the person transfers in and out of the tub or shower, how each part of the body is washed. And it doesn't include the washing of back and hair. And the reason is that this is difficult at the best of times, even if you're in tip-top shape. So we didn't, the interRAI researchers who designed these instruments didn't want to include that to make it, because it could seem that somebody's actually worse in doing their bathing because they're unable to wash their back and hair. So that they've left that out when you're looking to assess for this particular item. Personal hygiene looks at how the person manages their hygiene, including combing hair, brushing teeth, washing of face, hands, shaving, applying makeup. And this, of course, excludes baths or showers because that is captured bathing. Next items look at dressing upper and dressing lower body. So for upper body, how they dress and undress in street clothes and underwear. And if they're in hospital, whatever is the type of clothing that they would wear throughout the day. If it's street clothes, that's great. If it's a Johnny shirt, then you would include that. So whatever makes sense for the environment that they're in, particularly in hospital. This also includes prostheses, orthotics, fasteners, pullovers, those types of things. And for dressing lower body, it's dressing below the waist, including those same items, prostheses, orthotics, street clothes, underwear, and again, Johnny shirts. Shoes are also included. Walking is next, and we want to look here at how the person walks between locations on the same floor indoors. And again, with all of the ADL items, we're looking at what type and level of assistance is needed. And it's the same for this question too. You want to know what type and level of assistance is needed to walk within a 3-day period. So for the last 3 days. Locomotion includes how the person walks between locations on the same floor, either walking or wheeling. Pardon me. It includes how the person moves between locations on the same floor, walking or wheeling. And if they use a wheelchair, you want to look at their self-sufficiency once they're actually in that chair. So we're not looking at them getting in and out of the chair. Once they're in it, how are they getting from point A to point B? And this can be movements in locations inside and outside. Transfer toilet, this one here looks at how the person moves on and off a toilet or commode, or if they're using a bedpan, how they're also getting off and on that. And I just want to make a mention here about that currently there's no item in this form or the long form of the home care instrument to measure transfers to and from the bed, toilet, or chair. Oh, pardon me, from the bed and chair. This one looks at toilet. And this was removed in the instrument. In an earlier version, they did have transfers from bed to chair, but they did remove it. And the thought was that the transfer to the toilet would capture this information. And I have to say it's a little controversial. I think a lot of people do not agree with it. I have to admit I'm one of them. However, interRAI does have a training committee, which I'm fortunate to sit on, and questions like this that come to us where we're saying, you know what, this doesn't quite capture what's really happening with the person in the community or in the hospital. Could you consider putting it in? Those questions come to us, and what we do as a committee is we try to make a decision that would make the most sense for those who are putting those questions to us, and take that decision as a recommendation to the interRAI researchers who designed these tools to hopefully have them reconsider and use some of these, bring back some of these items or design something new so that it will really capture what it is we want for our clients. I always say, interRAI is designed by a bunch of researchers and clinicians, and the researchers are great, but sometimes, they're not on the ground. They're not the ones doing the assessment, so they sometimes miss the mark. So it's great that assessors who are out there using this instrument can say, hey, this doesn't quite work, and have a vehicle to escalate their concerns so that hopefully the researchers will understand the need to make a change. So I'm just putting that out there in case you find something that doesn't quite make sense and you'd like to see a change. Just make sure that we get that information and we can send it up. Oops. Toilet use is our next item here for the ADLs, and it looks at how the person uses the toilet. So this includes a commode, a bedpan, a urinal, how they clean themselves after toilet use or after they have an incontinent episode, how they change their bedpan, adjust clothes, manage ostomies, And of course, it excludes the transfer on and off the toilet because the item we just talked about captures that piece. And the last one here is eating, how the person eats and drinks regardless of their skill. This can include tube feedings and TPN. So that is ADLs. Again, it's a little bit more challenging than some of the other sections, but believe me, once you start doing this, you'll be able to get it no problem. It just takes a little bit of time. Section H, question 2, looks at incontinence. And really it's, as we know, urinary incontinence is not a normal process of aging. It causes many problems. Skin rashes, falls, isolation, can lead to pressure ulcers, and the potentially troubling use of indwelling catheters. And it can definitely be embarrassing for our clients, so asking these direct questions about incontinence is the first step to help us with a care plan and determining needs. So this one here, you're just looking at urinary collection devices. It excludes pads or briefs. And of course, consult directly with the person or your notes, chart notes, that type of thing. You can get this information. And what it's looking at here is catheters mostly. If they don't have any, then of course it would be none. A condom catheter is for men only. An indwelling catheter, in this case, they're looking at continuous. And then item 3 looks at cystostomy, nephrostomy, urostomy, and they're not asking you to determine what of the 3 they have. If you have that information, that's great. But if you know it's one of them, then you would code this as a 3 to capture that particular item. Next, we are looking at really the presence of diseases or infections that are really relevant to a person's current ADL status, their current cognitive status, mood or behavior status, medical treatments, nurse monitoring, or risk of death. For this one here, we really just want to capture conditions that are very current. And, you know, I think that a lot of us were so used to collecting information that's happened on diseases or infections that have happened so long ago because that's just our training. We're just used to it. But for this one, try not to capture conditions that have been resolved or no longer affect the person's function or care needs. Because with these items in the interRAI instrument, they're really looking at a snapshot. As I mentioned, a lot of times we're just looking at the last 3 days. Did these things happen? Did they not? And some of them will look at items that are a longer period of time, but they're still very current. And this is one of those questions. So the types of conditions here, you're only going to be capturing one, but they're often associated with the type and level of care needed by the person. And the way that we're coding this is, the item that we're looking at here is pneumonia, and that's, of course, inflammation of the lungs, most commonly of bacterial or viral nature. And these are the choices that you have in capturing pneumonia. Either it's not present, or it is the primary diagnosis, or the diagnosis for the current stay. The diagnosis is present and they're receiving active treatment, or it's present and monitored, but no active treatment is being provided. So this is what you're looking for this particular question, section I-1. Section J3 looks at health conditions, and particularly it's looking at problem frequency, which is capturing balance and pulmonary issues. And coding for these items are as follows, and as you can see on your screen, not present. And maybe they're present, but they haven't been exhibited in the last 3 days. And this question is new to interRAI instruments, and I'm glad they put it in because oftentimes, you know, somebody might have experienced something outside of a 3-day window, that's still very current, but you wouldn't be able to capture it. And this gives you the opportunity to do that. So it didn't happen in the last 3 days, but it happened 5 days ago, or it's been addressed, but it's still a concern, either on behalf of caregivers, staff, family, or the client. So if it's still a concern, but it hasn't been exhibited in the last 3 days, this is the opportunity for you to capture that information. And then our last codes are it happened once, twice, or every day in the last 3 days. So the items that we're looking at here are first 4 are for balance, and it's looking at difficulty with moving self to standing position unassisted, difficult or unable to turn self and face the opposite direction when standing, dizziness, and unsteady gait. All of these questions can definitely be related to falls and will provide further insight into the person's condition. And then our last item here is pulmonary, and it's difficulty clearing airway secretions. What they mean by this is the person cannot expel sputum from the mouth or trach regardless of their diagnosis. So those are the 5 items that you're looking at under health conditions. Pain, this is a large one, and lots of our clients have pain. I think pretty much everybody does. But what we're finding here, what the interRAI researchers have found, that quite a few persons with pain receive inadequate or no treatment, and in particular those with chronic or non-cancer related pain are often overlooked and not treated. And part of it is because people mistakenly believe that pain is to be expected as one ages and nothing can be done to resolve it, which of course is not the case. The presence of pain can increase suffering in other areas and can lead to increased sense of helplessness, anxiety, depression, decreased activity, decreased appetite, and disrupted sleep. So it's quite invasive and it affects all parts of a person's life and other parts of their health. So it's something to definitely look at. The definition of pain is an unpleasant sensory and emotional experience that is generally associated with actual or potential tissue damage. And of course, pain is highly subjective. It's what the person says it is, and it can be described as burning, hurting, soreness, aching, pain. The person can moan, wince, or guard the area that's painful. So it can be verbal and nonverbal signs of pain. So for this question here under pain symptoms, you want to record the frequency and intensity of the pain the person is experiencing, as well as any control measures that are in use. This first question here looks at frequency, so how often the person experiences pain through verbal and nonverbal signs. And the coding for this is no pain, present but not exhibited in the last 3 days. And again, it's very similar to the last item I talked about. Maybe they haven't had pain in the last 3 days or even the last month, but they're still concerned that it's going to be an issue. So if that's the case, it would be present but not exhibited in the last 3 days. It can be exhibited once or twice or every day for the last 3 days. Next pain question looks at pain intensity, and this measures the level of pain reported or observed in the person in the last 3 days. And it could be no pain, again, mild, moderate, severe, or times when the pain is horrible or excruciating. And again, pain is subjective, so it's what the client says it is. You can use whatever items you've used to determine pain before. Sometimes there's different pain scales that you've used. I know in long-term care homes, they've got the visual pictures with the faces. The name has just left my mind right now. But whatever devices or instruments you need to use to try and get the person to really describe whether their pain is mild or horrible or excruciating, use it for this item. And then pain control is our third item here, and it measures the current therapeutic regimen to control the person's pain and describes the adequacy of pain control measures, which can include medications, massage, TENS, acupuncture, or other methods. And then you can see how you're going to code this here. So if they have no issue of pain, then that's a 0. Pain intensity could be acceptable to the person, so no treatment regimen or change in regimen is required. It's controlled adequately by a therapeutic regimen. It's controlled when the regimen is followed, but it's not always followed as ordered. The regimen is followed, but pain control is not adequate, or there is no therapeutic regimen being followed, and pain is not adequately controlled. So those are your choices to capture pain control for your client. J7 looks at instability of health conditions. And the first item here is the person is experiencing an acute episode of a recurrent or chronic problem, or they're experiencing a flare-up of a recurrent or chronic problem. And an example of an acute condition could be the flu, a drug reaction, and a recurrent acute condition can include a UTI. A flare-up or chronic condition can include new shortness of breath for someone with a history of asthma. So those are just a few of examples that you can use for this item, and it's a simple yes or no for the response here. Next question looks at end-stage disease, 6 or fewer months to live. And again, you can ask the client directly if you feel that it's a topic that they're comfortable with, or of course, talk to caregivers, staff, or refer to the chart. Again, this is a simple yes or no response. Next one looks at nutritional items, and this is actually K2. We forgot to change this. It's K2 instead of K1. And for this, it's looking at weight loss and fluid intake, those types of things. And marked unintended decline in weight can indicate failure to thrive, and it's a sign of potentially serious medical problems or poor nutritional intake due to physical, cognitive, or social factors. So it's very important items to capture here. So weight loss is the first one, and we're looking at 5% or more in the last 30 days or 10% or more in the last 180 days. And for this one, it may be a little bit more easy to actually capture this if the person's in hospital than community. So you're at an advantage in that case. So just look at chart notes for the information here. Dehydrated or BUN or creatinine ratios are greater than 25. If you have that information, that's great. But if you don't, and in some cases you won't, you can use examples of dehydration such as a dry, sticky mouth, thirsty, sleepiness, tiredness, dry skin, poor fluid intake, sunken eyes. Those types of things indicate dehydration. Fluid intake is less than 1,000 cc's per day, or less than 4 8-ounce cups a day. And fluid would include water, juices, milk, soda. And then our last one here is fluid output exceeds input. This would be someone who may be experiencing diarrhea or vomiting. Definitely more is coming out than has gone in. So these, again, are just a simple yes or no response to these 4 items. You just code as appropriate. K3, this looks at mode of nutritional intake and looks at the person's ability to swallow all types of food and any modifications needed, and also includes tube feed. So quite a few choices here when you're on capturing the mode of nutritional intake here, from normal, they can swallow all types of food, modified independent, liquid could be sipped, or they can take limited solid food, The need for modification may be unknown, so they may or may not need it modified, but they're definitely taking in their nutrition a little bit differently than what would be considered normal. Requires diet modification to swallow solid food, so this could be a mechanical diet, so it's pureed or minced, or maybe they're only able to ingest specific food. Requires modification to swallow liquids, so maybe those have been thickened. Can swallow only pureed solids and thickened liquids. They can have a combined oral and parenteral or tube feeding. Maybe they have an NG tube feed only, abdominal feeding tube, it could be a PEG tube, parental feeding only, and which can include TPN, or the activity did not occur. And that's during the entire period, which is the last 3 days. That would be unusual, but it could happen for sure. So you might want to capture that if that is the case. Next, we move on to the most severe pressure ulcer. So again, you should be able to capture this information through chart notes or talking with your colleagues in hospital. And for this one here, if somebody has more than one ulcer anywhere on their body, we're looking at the most severe one. So keep that in mind when you're looking to code for this. So we have from no pressure ulcer to any area of persistent skin redness, partial loss of skin layers, deep craters in the skin, breaks in skin exposing muscle or bone, or it's not coatable. So you don't have to stage these ulcers, and these definitions do correspond to the stages of ulcers from stage 1 to 5. Don't have to code them, and again, just refer to notes to get the most accurate information so that you can code this. Section N, this looks at treatments and programs received or scheduled in the last 3 days. And for this one here, you're coding the way that you can capture this information for the items is that it wasn't ordered and it didn't occur in the last 3 days. It was ordered in the last 3 days but hasn't been implemented. It was implemented in once or twice in the last 3 days or daily in the last 3 days. And the items that we are looking at for this, these items represent a lot of the skilled medical needs that figure into Indiana's definition. So what we are looking at here are the IV meds. So for IV medication, this does not include a saline or heparin flush to keep a line patent or IV fluids without medication. So please keep that in mind when you're capturing it. Oxygen therapy, suctioning, trach care, ventilator or respirator, wound care, and a turning and repositioning program. All of these items are captured under treatment and procedures. So I think, Debbie, at this point, I'm going to turn this over to you so that we can continue on with your additional questions.
Okay. And these additional questions, and I'm noticing on the screen it cut off a little bit of the text there. In the print version that we'll post online, you'll be able to see that better. Those questions that Roxanne has gone through, and thank you, Roxanne, are from the interRAI tool. As we map those elements to our current eligibility screen tool, there were some items that were missing. And so we've added 7 additional questions to capture those. And these are basically formatted as yes/no questions with some guidance accompanying them as you answer that. So this first one is in reference to the acute rehabilitative therapies that we mentioned earlier as one of the skilled needs that might qualify a person for nursing facility level of care. And again, you'll note some of this is that general strengthening exercise programs and habilitation are excluded. It should be a medical condition, which requires this acute rehabilitation. Again, not habilitative therapies that you might see with individuals with intellectual disabilities where they're trying to gain skills that they never had. This is the regaining of skills that were lost due to some sort of a medical condition. So often there will be a comment field there where you can provide a little additional information on types of therapies. A lot of that is in your H&P though, and I just answered a question in the chat. You know, your H&P will be a document that's uploaded with this assessment tool for the Ascend clinical reviewer to use in their assessment process. So you're getting a lot of additional information from that fills in some of the background information around the assessment tool. But kind of looking at those kind of questions to determine whether this is a situation where they need direct assistance from others for some sort of therapies, treatments that are acute and rehabilitative in nature and that must be followed at least 5 days per week. Again, because these are acute rehabilitative needs, there's an assumption that they are short-term in nature and that person's functioning level is likely to improve and be better when those therapies are completed. So when the Ascend clinical reviewers look at this and see a yes answer for acute rehabilitative therapies, they know right off the bat they're probably looking at only a short-term approval for level of care. It's not likely to be long-term. It could be if there's other conditions involved, but if this is really the sole basis for the level of care determination, it's likely to be a short-term approval for placement just for 60 days or 90 days, whatever they think is appropriate to that individual's needs. If later on it turns out that something else happens and they need a continued stay request to stay longer in the nursing facility, then the nursing facility will submit a new assessment form. They'll use the long form then for the interRAI and do a complete assessment of that individual's ability to return to the community or whether they have long-term nursing facility level of care at that point. So this is certainly an important piece of level of care, but it does normally indicate that it's a short-term level of care. The next item is, again, a skilled...
Yes. We can stop. We don't have to keep watching it. There's a point of this.
Double check your phones. We're getting a little bit of background noise there. Just to be sure everyone's muted. We've done really well with that so far.
Oh, hello?
Yeah, so if you could double check that your phone's muted, we're getting some background there. Thank you. Okay, so this is another skilled need, is direct assistance from others required for intravenous or other injections more than one time per day. And note this is other than insulin injections for an individual whose diabetes is under control. So you're looking at, what are the medical conditions that require this, what medication is involved, what's its purpose, again, how often, at least one time a day, and then seeing if how the injections are administered meets the requirements for a yes answer here. So if the H&P captures all that information, that makes it easy. There will be a narrative section in Ascend where you can put some notes and comments into the reviewer. The more specific you can be, the more likely it is the reviewer is not going to have to request additional information from you, and that means you get a quicker decision back and you're ready to discharge. So that's a plus for everybody. This question is also in relation to skilled medical needs, and it's related to the need for medical observation and physician assessment at least every 30 days. But the real key is that they have a changing and unstable physical condition. And that's typically evidenced by frequent changes in physician orders related to medications, diet, oxygen levels, other treatments that they may be receiving. So you're really looking for what is it about their condition that is unstable and changing that justifies this kind of a check mark for a skilled need. Is their condition really unstable that would require nursing intervention and observation? Because remember, all of those skilled needs that qualify for level of care in Indiana are all really things that reflect the need for a nurse in the absence of the primary caregiver. So you can, ask things about how long has the condition been considered unstable. Again, unstable conditions are usually somewhat acute in nature and maybe short-term and passing. So the reviewer is certainly going to look at all the circumstances around that, and it may be one of those other trigger points that says, this isn't long-term level of care, this is short-term, they're going to get stabilized, and then the situation's really going to have to be reassessed before they could stay longer in the facility. So those are the kinds of things. Some of these questions, particularly the one about dates they saw the doctor and all of that, really are more for our home and community-based services side, for the case manager assessing someone in a home to get a sense of how often they've seen the doctor. If you all are doing the assessment, they've obviously seen them pretty recently because they're there in the hospital. So there's very active medical intervention going on. So it's a little bit different guidance there. This is the last skilled need that we added to the interRAI tool, and this is related to uncontrolled seizures. And really the question is fairly simple. There's some guidance there in how to look at this, but if the primary caregiver wasn't there, if they were at home by themselves and the primary caregiver wasn't there, would it require nursing level intervention for the safe management of uncontrolled seizures? Would there need to be a nurse that would administer whatever the intervention was should they have a seizure without their primary caregiver being present? So describing, how unstable their seizures are, how often and frequently they have those seizures, that's all important information. If they have a seizure management plan, and you can make that part of your H&P or other documentation that you submit to the Ascend system so that the reviewer can see that. Again, the more information you can give them, the less likely it is that they're going to ask you for follow-up information to make that decision. So those were all skilled needs. These other items, we've got, I think, 3 more questions here. These are more related to those items that we refer to as activities of daily living. They're really, again, not part of those core federal ADLs, but things that Indiana considers as part of the expanded list of activities of daily living. This one's pretty rare to really find happening, particularly in a home care situation, but if the individual requires daily recording of the kind and amounts of solids and fluids, both intake and output, they could have a yes answer here. So looking at, why is that really required? Is it really as involved as that, as daily recording of everything going in and out? And documenting who's doing that will help to get a quicker response there. This one is in reference to passive range of motion. Do they require assistance with that on a daily basis per their medical plan of care? So again, describing what condition prompts that, what is the frequency, who is assisting with that, why do they need assistance with it, will again help the reviewer make a decision about whether they agree with that response or not. This one is a little bit confusing, but basically they are stable. It's not an unstable medical condition, but even with a stable medical condition, does the individual, for whatever reason, and you need to document that clearly, but do they require a licensed nurse to be monitoring his or her health plan on a 24-hour-a-day, 7-day-a-week basis? So really looking at that and what is, in spite of their stable condition, how is it complex enough that it requires a nurse all the time? I think in a lot of cases, if that's the case, there probably is an overriding skilled medical need. So you probably kind of already have an item that's qualifying them in that section, like that they're on a vent or something for that matter. You know, that would require 24/7 nursing supervision if they're getting 24/7 vent support. So this one you won't see used all that frequently, but it is available as an item that's part of our level of care definition. So I'm going to pop down here to the chat and check some questions, but on the screen now are the other two dates that we will present this exact same webinar. It will be this exact same information. And then there is the link there to our PassR page. If you haven't already visited there and signed up to get the automated email updates, we have newsletters that are going out pretty much every week with information about the changes. Usually 1 week Ascend will send something, and then the next week the Division of Aging will send something. Those will probably ratchet up in frequency over the next couple of weeks as we get very close to the 7/1 start of the Ascend system and the new rules around PassR. So it's really good if you get on that list so that you see those updates. And even after 7/1, we'll continue to use that to get updates out to people on best practices that we're seeing, on frequently encountered errors. We'll continue to update the frequently asked questions section, and all of that will go out through those listservs. So there's one you can sign up for on our page. There's also one you can sign up for on the Ascend page. Both of those links are in the chat, so you can get to those. There's lots of resources that are starting to be posted to both of our pages. The provider manual that's on the Ascend page, and I believe there was a question about where to find that. If you go to the Ascend AMI.com site, right kind of in the center of the page on the left is a drop-down box to select your state. And you can click on that and pick Indiana, and it'll go to Indiana's Tools and Resources page. And I think the manual was about the third link down. You'll see it kind of under training. It'll say Provider Manual. And that is a very detailed document that we've been working with Ascend on for many months now. And it really walks through just every scenario you can imagine that you'll encounter with nursing facility admissions and lets you know kind of step-by-step what the procedure is. Now, there'll also be other user manuals that will be posted. Those are not up yet, but they will be posted that really show you the mechanics of how you enter the stuff into the Ascend system. It really walks you through step-by-step. We will have, one of the questions that came up in chat a little while ago was whether people would get a chance to try out the system. There is going to be a brief piloting period where some folks will get a chance to test the Ascend system. We have already drafted volunteers. Of course, we have lots of people interested in that. So we have a collection of about 25 folks spread across nursing facilities, hospitals, and AAAs that will be able to play in the system for about a 10-day period starting next week. And they'll be able to give some review and comment and feedback to Ascend, not so much on the system itself, but on the tools that are available. Does the user manual give them everything they need to get through the process? We've been doing a lot of webinars with Ascend, and they've been showing you the mechanics of how the level 1 works and how the level of care works. If you missed any of those that have been occurring really since January, those are all posted on the website, and so you can go back and catch up on any of those and get to see exactly how it looks when you're putting this level of care information into the system. There'll be some more training opportunities. There's a number of training videos that Ascend is posting to their site. There's stuff adding all the time. There's a fairly lengthy FAQ document that's available on the Ascend site, and it is searchable. So you can, look for a word or a topic specific to what you're having an issue with. We are putting together a separate FAQ document related to getting registered as a user in the Ascend system, particularly for the administrative users that each hospital, nursing home, and AAA would need to have to manage their other users. We've been doing those enrollments for the last week or so now, and we have, I think, a little over 100 either hospitals or nursing homes already enrolled with administrator accounts, so that's great progress already. We've got a lot more of you to do in the next couple of weeks so that everybody's ready with access to the system. Again, you'll get all of that if you sign up for the email updates. You'll get the notices when those new FAQs post as we add to the existing list or we create the new list for folks that are just starting to get enrolled. So I was talking a lot there. Let me take a breath for a second and go back and catch some questions here. And I'm going to answer some of these verbally, but we will make sure that answers get posted online. Okay, so I talked about where to find the manual. There was a previous webinar that talked about the level 1, and you'll find that on the Ascend website. Question, is this required for all clients going to skilled nursing facilities, or rehab, or only for Medicaid patients? Level of care is really only for Medicaid patients, the exception being those individuals that trigger a level 2, and then also need to have a level of care completed.
And level 1 is required.
And I think there's been, some questions in here. Yeah, I'm sorry, I'm getting a prompt. I have Becky Kors in the room with me too, and she's making sure I don't screw any of these answers up. But you do, of course, have to do a level 1 for anyone who's admitting to any skilled nursing facility that accepts Medicaid. Even if that person is not a Medicaid recipient, everyone admitting, even for short-term rehab, has to go through the level 1 process. As long as the level 1 doesn't trigger a level 2, and as long as they're not a Medicaid recipient, then you don't have to worry about the level of care piece at all. And of course, that's one of the big changes with this new system. Our current Indiana statute requires us to do a level of care assessment on every individual, regardless of their Medicaid status. There's some timeline issues there, and the AAAs do that work currently. And so the new system is saying, no, you only have to worry about that if they are a Medicaid person or they have triggered a level 2 review. There's a question about should the nurse help complete this form, that maybe the discharge planners would not be able to answer some of these questions. I think it can certainly be a combination. Our belief all along, particularly in conversations with the Hospital Association, has been that hospitals have a lot of this information already in their records. And so some of this is kind of just learning to figure out where in the record are you going to find the answer that someone has already collected as part of your assessment and admission process with that individual. So I think in that way, yeah, there is a nurse involved because you had nurses who were collecting that and assembling their record, if you will, that you're going to pull that information from as you fill out the form. And so, Ascend has indicated to us they've implemented similar systems in a number of other states where hospital discharge planners have been new to this same role and kind of doing the same sort of thing. And they've reported, that in the beginning it's going to take a little bit longer as you start to figure out where things are kept in your records and how to kind of map that into the correct answer on the assessment form. Part of it is maybe looking to see, do you have any gaps? That's why we shared very early on a couple months ago the level of care form as well as the level 1 on the website so that you all could start to look at that and say, are there things I'm not collecting that I should make sure the admitting nurse or other staff gets into the file so that when I'm ready to enter this in Ascend, it's all kind of there at my fingertips. And so I think as everybody evolves and gets better at doing that, your data entry times are going to go way down. And you're going to find it's much, much quicker. And again, you're going to get very quick responses from Ascend. particularly if you've made sure that you've submitted as much information as possible. If they have to ask you for additional information, that obviously is going to add to the time a little bit. But if they have everything they need, they're required by contract to issue a decision to you within 6 business hours. Their actual times, from what we understand, run a lot shorter than that in most states. So we think you're going to see really quick responses, not just on the level of care part for Medicaid recipients, but even on your level 1s. It's going to be very, very quick. Let me go back here. Nurse. How are nursing facilities made aware when someone is approved to come from the hospital? Essentially the same way they are now. I mean, you need to be communicating with the nursing facility and letting them know. But when they're ready to accept a patient and admit them, they'll go into the Ascend system in a section called Path Tracker, and they'll be able to record that they have accepted and admitted the person. They can see then that everything was approved. They'll be able to have their level 1 and copy of the level of care right there in the system for them. So you don't have to exchange paper with them anymore to get them that information. This is kind of another question about the nurse helping with the assessment. No, so nurse does not necessarily refer to licensed personnel only. It should be someone trained in the use of the assessment tool and in the use of Ascend. And so these webinars are really the start of that training process. We want you to at least get familiar with what the tool looks like. We'll continue to do webinars into July. We think it'll help when people have a chance to actually use the tool some and then get some additional training. We will also have a self-paced online training system that Roxanne and the folks at Relias are helping us to get stood up. Probably third week or so of July, they'll have that ready to go. We'll get it out to everyone as soon as we can. So we'll help reinforce the use of this assessment tool and the questions that are on it. So it isn't necessarily what we would call licensed personnel. I do want to caution there, was a few questions about, worried about discharge planners maybe not knowing the answers or just filling it out best they can and moving on. It is a formal assessment process, and part of what we think is the advantage of this new system is we all kind of become partners in this together. Hospitals, nursing homes, Division of Aging, and the area agencies on aging all have roles and responsibilities here to make sure Indiana's system works as efficiently and effectively as we can, and that we end up with people in the right care settings at the right time, receiving the right care and support. And that really is what PASSR is kind of all about. And so we want people to take that responsibility kind of seriously. And you'll note there's language on the form about submitting incorrect information is potentially Medicaid fraud, and we're not trying to scare anybody with that, but we do want people to take it seriously and know that you're attesting that this information is correct to the best of your ability. And that's really what we're asking people to do, and be focused on getting the information processed not just efficiently but correctly. And so that people end up in the nursing home if that's where they need to be. And if it's not where they need to be, how do we connect them with the appropriate services elsewhere? And that's, again, the heart of PASSR, particularly with regards to the mental health population and intellectual disability population. If they do trigger that level 2, that's what the whole level 2 process is about with PASSR. Is the nursing facility really the place for them? And if it is, for even a short term or a long term, what other services do they need to truly support them and their individual needs? So I just want to encourage everybody that, we really do see this as a chance for everybody to gain from some increased efficiency and a more paperless system. But it's also a responsibility for everyone to do their part. And nursing facilities certainly aren't going to like it if you're trying to transfer to them people who don't meet level of care standards, because then they're going to have payment issues and survey issues, and they don't want that. So everybody needs for each of the partners in this system to complete information to the best of their abilities and get it as accurate as they can so that no one gets left holding the bag. There's a question about when will nursing facilities be trained on the long form as well as when the different assessments are to be completed. There's information already online. There's some kind of reference documents as well as the provider manual itself that outline when you do the long form and when you do the short form. For the most part, the short form is the purview of the hospitals, and the long form is the AAAs and the nursing facilities. We will do some additional trainings around the long form, but we don't have any planned immediately. We want to concentrate on the short form questions. Those are part of the long form. But for nursing homes, I don't think you're going to find that the interRAI is all that much different than your MDS tool. You're going to see much similar questions. The layout of the questions, the potential responses are going to align very closely to your MDS tool. So we'll probably do some webinars to help kind of coach through that, but we aren't as concerned. This shouldn't be as foreign to the nursing facilities as it is for hospital discharge planners who are really taking kind of a new role in this. So we will have some trainings, but I think we're less worried about all of you because you're so familiar with the MDS. That'll be a real advantage to you. The online training and certification is not yet available. Relias is making the modifications to add R7 questions and also to be sure that there's a shorter version of the training for hospital discharge planners who are only doing the short form. So as soon as they get that ready, we'll get things up and running with that. There's a question about starting the assessment on day one, the patient that's there 24 hours, how do you assess for the 3 days? You know, part of it is conversation with them and their caregivers. And again, I think that really in large part is part of your assessment and admission process, your treatment process with the individual. They're there to receive some sort of care, and so you're probably having conversations about what their last 3 days have been like, what kind of things they can and can't do for themselves. So you don't have to wait 3 days to observe them. You're asking them and their caregiver questions about what the 3 days have been like. If you really have had them for 3 days, then you'll have good notes and documentation on that. But you certainly don't have to wait for that 3 days to happen. What happens when a patient is unable to answer questions and there are no family or others to answer? You know, that's probably an indicator that there's a lot of needs there. And again, you have to assess to the best of your ability and provide all the information that you have available in the H&P. And part of that's just going to be explaining why they can't answer those questions. And those are probably all going to be contributing factors about their capacity that you can reflect in the assessment tool, and very likely maybe part of what indicates level of care for them. Training on the actual program, and I assume actual program means the Ascend system. And again, we've been doing that for the last 3 or 4 months. And so there are a number of webinars already posted online that walk you through the completion of path tracker activities, as well as the level 1 activities and the level of care form. They'll continue to add to that body of training materials. There's a number of training videos that are available. The user guides will be available as soon as the pilot testing phase is over, and those are very detailed and really walk you through step by step what button to click when. It is, we're playing in it a little bit this week. Becky's playing in it more than I am, but it's very intuitive, so you'll find it very comfortable and easy to use. There's not a lot of secret buttons that you have to know where they are. It really flows very well from one question to another. This is a question about administrator registration. I'm going to skip that one, but we'll be sure we get an answer online for that. Self-pays and pending Medicaids. If it's not a Medicaid recipient or it's not a level 2 trigger, you don't have to complete a level of care assessment at all. So no, they're not doing this screen. You would only be doing the level 1. A question about where the actual level 1 and level of care forms are located. They're on our website and the Ascend website. So you can get a copy of the level 1 and the level of care from there. The short form is printable. The long form that's posted on those websites right now is view only. It's not printable yet, but we'll get that corrected as soon as possible. But for hospitals, you only need that short form anyway, and that is there and printable. Does this apply to all types of Medicaid? Yes. As long as they're a Medicaid recipient, there's a chance that their Medicaid may be covering their facility stay, and so we need to complete the level of care.
They still need to work with Medicaid for the appropriate aid category.
Yes, and Becky's noting that on the nursing facility side, then, if they do want Medicaid payment, they're going to need to make sure that they get into the appropriate category that will offer that coverage. But in terms of the level of care assessment, yes, it triggers it. So this question is probably more of a level 1 question. I don't know if you can give it a quick answer, Becky. What about patients who are on psych meds who pass a depression screen?
Okay. Good afternoon, everybody. Hopefully people can hear me. The good thing with the new level 1 tool, it's a very comprehensive tool. And so it will walk through lots and lots of questions to help to identify, what kind of diagnosis the person has, what kind of medications the person's on, why are they on this specific medication. And so you may have someone that has a mild depression, and they might be taking a psychotropic medication to address that depression diagnosis. And with the supporting documentation and everything that's provided, he may not end up needing to trigger a level 2. Yeah. So it basically will depend on, the outcome of that level 1 review. For many of you, hopefully folks have already looked at that level 1 tool. It's like a 4-page document. And so again, it asks lots and lots of very specific questions. And so it's way better and different than our current existing 7-question level 1 tool.
Thank you. Let's see. We have a couple different questions here about emergency admissions, and we had a question earlier to that, and I'm going to refer you specifically to the provider manual from Ascend. Section 1.51 covers the emergency admission procedures. So take a look at that first, and you're going to find as you make requests for help, and there is a help email address, and we should add that to the slide. I'll give it to you here in just a second. The first place we're going to refer you an awful lot of the time is to the provider manual. We have spent a lot of time with Ascend over the last several months developing that manual so that it'll be a really good resource for folks. And so we really want people to get used to referring to that right away. And if you don't find answers there, your second line of defense is the FAQs. So learning to utilize those two things will get you quicker answers to things in most cases. We do have an email set up for other help questions and inquiries, and that is PASSRR, P-A-S-R-R, at fssa.in.gov. And I'm going to type that into chat so you'll see it. And that is active and available email now for you to send any questions or comments that you have. And we're still trying to kind of get geared up and able to answer them as quickly as we will post 7.1, but we're starting to get some inquiries into that address now related to the administrator sign-ups. So it's active and available. Undocumented citizens, I don't believe that undocumented citizens can get Medicaid coverage for nursing facility stays. I think they can only get Medicaid coverage for emergency medical treatment in the hospital. So I would be very surprised to see a facility accepting an undocumented individual. They would never have the appropriate Medicaid coverage for a nursing facility. If they did and they're Medicaid, then yes, complete the level of care. But I think that would be very unusual. Paperwork for an emergency admit for a Medicare patient. Again, I would refer you to those emergency procedures. It doesn't matter whether they're Medicare or not. The emergency placement procedure is exactly the same. I see that the H&P is listed as a required form when submitting the level 1, and there may not be an H&P immediately available for emergency room patients. You need to provide all the information that you have. If you can get a hold of an H&P, they really need that to make their full assessment. Again, the more information they have, the quicker that they'll be able to get you an answer. The second part of your question is referring to the patient needing an emergency placement. So again, I'm going to refer you to section 1.5.1. I have a feeling I'm going to remember that section because it will outline the emergency procedures, and they're different. You know, if you're looking for that emergency placement, that 7-day placement period, some of the requirements around that are different, and it allows you some time to collect that information post-admission. Particularly if the admission is happening outside of business hours. But that section of the provider manual outlines all of that for you. What happens if you assess a patient on Friday and do the level of care for a level 2, and then the next week they find out they have improved and your assessment does not match? You should update your assessment if that's the case. I mean, hopefully there were indicators in the assessment of the short-term nature of their situation if they improved that quickly the next week. The level 2 will likely still be in process. It's unlikely if you requested the level 2 on Friday, it's probably not going to happen on Friday or Saturday. It's more likely to be Monday or Tuesday at the earliest. So you would want to update your level of care assessment information at that time. And I believe you would do that. I may be speaking incorrectly. I'm not sure. I don't think we have anybody from Ascend with us today to correct me if I'm wrong, but you would enter a whole new level of care assessment. There's not a way to edit your previous one if it was already decided. You would enter a whole new one.
Right, at the assessment piece, when you go online. This is Becky. When, in that case, because you've already started that level 1, that level of care, and now you want to change because there's been a significant change. When you go to the Ascend system, there'll be a checkbox. You can select the reason there's been a significant change. That's the reason, and then that will take you to the appropriate screening tool. So you'll be able to update that accordingly. You'll be doing a new one, but it'll be updating for that individual.
There's a question about exactly where those forms are located, and I can't see a website handy right now to exactly locate them, but we'll be sure that is in the FAQ section, and we get that out to folks. In the meantime, if you are still having trouble locating them, use that PASSR email address, and we'll be able to shoot you a quick response. But
it should be listed
I don't think
under
they're
under
yeah,
resources.
Becky said it's under resources, so I don't think we tried to hide them, but it's not always intuitive where we've put things. So this is kind of a level 2 question, Becky. If the patient was a level 2 in the past, are they automatically a level 2 with this system?
If the person triggered that original level 2 and the determination came back that he does have a mental illness because he carries a schizophrenia type of diagnosis, for example, then yes, he's going to trigger that level 2 again. However, if he has schizophrenia and now he has developed the dementia, and the dementia is going to be primary over that mental health issue, then, you know, if he was in the nursing home, had the level 2, he went home, and now he needs to go back into the nursing facility again, a new level 1 would be generated. And so you would identify that he has a schizophrenia diagnosis, and now he has dementia, and then you would be able to answer those questions accordingly. So, you know, he may or may not always trigger a level 2. It depends on the circumstance and situation at that time.
Okay. And let's see, where am I? A lot of out-of-state patients from Kentucky and Illinois that only need short-term rehab, where we still have to complete and wait on the pass, for example, knee surgery, hip surgery. You, again, always have to complete a level 1 for any individual admitting to a long-term care facility that accepts Medicaid. Even if they're not a Medicaid person, if the facility accepts it, then you have to do a level 1. And every facility in Indiana accepts Medicaid, so you're not going to get out of it that way. So pretty much everybody needs that level 1. But that's all they need is the level 1. So if the level 1 is negative, there are no triggers for level 2. To use your example, they're a knee surgery and they're rehabbing to home and within a couple weeks' time. If you do the level 1 and there are no indicators of mental health or intellectual disabilities, you're going to get a pretty immediate response from a SEN that you are good to go. If there's any indicators on there, you may have to submit some additional information to be sure that a level 2 is not required. But if they're not triggering a level 2, you should be able to move them along and do your discharge pretty quickly. And if they're not Medicaid, then you don't have to worry about the level of care piece. Again, here's another question about emergency placements. This one for individuals who don't have a level 2. Is the process different? Yeah, it is different, and that's all outlined in section 1.5.1 of the provider manual. So again, I'm going to reference you there because that's where I would go to answer that question. And rather than me reading it to you, just learn to use that as a good reference. Let's see. This is a question, will SWRCA, and SWRCA references one of the area agencies on aging, pull the paperwork from a sender? Will facility be responsible for delivering within 5 days? None of that matters at all after June 30th. In the new world, there's no requirement for you to send anything to SWRCA. The admission will happen if you're admitting somebody from a hospital. The hospital is going to be sure that that level 1 is complete. You'll get that from them through paperless through the Ascend system. There's nothing that you would have to go through SWRCA for in that instance. So there's nothing you have to deliver to anyone within 5 days. Someone notes they do have a facility that does not accept Medicaid and is not Medicaid certified, is Medicare only. And in that case, you would not have to do a level 1. We don't, there's no requirement, PASSAR requirements related to those facilities at all. If it's truly a facility that does not accept any Medicaid, then there's no requirement for the level 1.
And Debbie, I'll add on to that, if you do have a non-Medicaid certified nursing facility, and then that individual then wants to later transfer to a Medicaid certified nursing facility, then he's going to be subject to that level 1 and possibly that level 2 if he triggers a level 2. Same thing with the level of care review.
Good point.
It's going to be that next facility that will have to, take care of that.
Yeah. There's a question about the level 2 forms. Is there a new level 2 form? Where would you find it? On level 2 questions, we're going to defer those for now, but you're going to be hearing more about that. Within Indiana, the way these things are divided, the level 1 and the level of care piece are the purview of the Division of Aging. We monitor those processes, and so that's what we've been working to overhaul and recreate over this last year, really, more than a year. The level 2 pieces are the purview of the Mental Health Agency and the Intellectual Disability Agency, which in Indiana is DMHA and DDRS respectively. Those are our sister divisions within FSSA. We've been working very closely with them through this process, and we know they are both engaged in efforts to look at their level 2 processes, both the screening tool, assessment tools that they use, and the process in general, who completes the assessments, how long it takes, all of those pieces, how effective they are, how well they identify potential community alternatives, how well they identify specialized services that would be needed for those individuals. They really are examining all of that. They're just a little bit farther behind. They started later in their piece of it than we did because of the statute. The statute sunsetting on 6/30 is what put kind of a time constraint on us to remodel the level 1 and the level of care piece. But level 2 is going to follow shortly behind that. You're going to see big changes on that side as well. There's nothing we can share with you right at this time. DDRS and DMHA will be getting information out about that shortly, though. Excuse me. Turnaround time, what will be the allowed turnaround time to notify the hospital of an approved level 2 admits to ECF? I'm not sure what the allowed turnaround time means.
I'm not sure either, other than under federal statute, from the initial referral to the determination for an individual that triggers a level 2 from start to finish, it's 7 to 9 business days. Now, we also know that we don't want somebody to be held up in the hospital for any longer than what they need to be. And so, again, that's going to kind of go back, I think, to what Debbie was just saying in talking and working with our sister divisions, because they're going to have their own self-imposed turnaround times from time when that referral is made to when the expectation for that level 2 to be completed so that you can have that determination. And so that's going to be part of what they'll be finalizing and sharing with everyone.
If that didn't answer what you meant with that question, just rephrase and try again.
Yeah.
Will the facility still have to issue a 450B to SWRCA? No, there are no more 450Bs. 450Bs of both the paper variety and the e-variety go away after 6/30. Question is, what if they have Medicaid as a secondary? It really doesn't matter whether it's their primary or their secondary. If they are a Medicaid recipient, that would indicate that there's a good chance that the nursing facility will need Medicaid reimbursement for their stay, and so the level of care would need to be completed. That's the same question. Will the level 2 piece be completed by July 1st? No, it won't. It certainly would not be completed. Now, I expect you will have some clarifying information before July 1st about what their timeline is. If I had to tell you today, I think it's more in the September-October range for changes to the level 2, but they'll be getting some more clarity around that. And I think you'll see information about it before July 1st. But in the meantime, you know, the level 2 pieces will continue to work as they've had. Same assessments, same providers, things will stay relatively the same with that process. Someone has a question that they're a hospital that do their own level 2s, and how will those be submitted? That process really, I don't anticipate a lot of changes there, but that question really needs to go to DMHA, and we can pass that along and be sure they get in touch with this gentleman in particular about that. But they probably will be releasing some more general information to all hospitals that may be doing their own level 2s about what that process, what changes might be coming to that. I don't think there's a lot of change coming 7/1, but what it may look like as they make other changes to the level 2 process down the road, again, DMHA will be the source of information for that. Again, there's another question about emergency admission. Elwa, they are reading section 1.5.1, so good. And I think it does talk more about, it's not only talking about those who trigger level 2s, there is general information about what qualifies as an emergency admission. But yes, APS is always part of that process.
For the level 2 piece. Now, the frequently asked question document will also potentially provide additional information, specifically for if he happens to be in the emergency room. who needs to make that referral, what is that process, or if he's at home in the nursing facility making that request through Ascend. So both the manual itself as well as the frequently asked question document will cover more details on that.
Okay, so the combination of that then. Good. Okay. Level 2, question about same paperwork. Well, no, it's not the same paperwork. There's no application piece anymore. There's no 450B piece anymore after 7.1. No 4B, you'll do the level 1 in the Ascend system, and if it triggers level 2, you'll make notice to the appropriate level 2 provider, and the Ascend system does not make that notice for you, but it will have contact information readily available so that you call the appropriate, or call, fax, email, whatever you choose to do, get in touch with the appropriate level 2 provider so that they can get your level 2 scheduled. And then they'll return the results to you, and you'll indicate then in the Ascend system that you've received the results of the level 2 and what they are, and then you're ready to make your discharge. So 450B goes away June 30th. We complete the level 1 and are notified that the patient triggers. I think I just hit that. If they trigger the level 2, you're going to notify the level 2 provider directly. So in a way, again, what we've done here to try to streamline the system overall is we've tried to look at places where there was kind of a middleman in things and remove any unnecessary steps. And it won't be necessary for you to call SWRCA if you need a level 2. You can call that level 2 entity directly. For the case of individuals with intellectual disabilities that are triggering the level 2 based on that, you're going to call your local BEADS office, your Bureau of Developmental Disability Services office, and all of that contact information and a map of what your region is, if you don't have it already, will be available to you in Ascend so that you can pull it up quickly and see who to contact. For anyone with mental health issues, your level 2 provider is your community mental health center. And DMHA has provided us a list of contact information based on zip code for which community mental health center you should contact. So you don't have to go to SWRCA and then wait for SWRCA to contact the level 2, and then, so there's not this, we eliminate some of this telephone game back and forth. You can request the level 2 directly and you'll get it back to you directly, which should mean it's a little bit faster, and we've taken a step out of the process then. And hopefully I got this other question then. When you complete the, this is someone who's completing a level 2, who do you send it to? You send it to whoever requested it. And so if you're a hospital doing your own forms, you essentially requested it from yourself. So make sure that whoever's doing your entry in Ascend knows you've completed it and can enter the results of it so that the nursing facility will be able to access that when they do the admission. Asking for a repeat of when PASS is needed. I know that all Medicaid people and all Psych people. So yeah, let's go one more time with the basics. PASS-R really in and of itself is about the level 1 and the level 2. Every individual who is admitting to a long-term care facility and if that long-term care facility accepts Medicaid at all, so it doesn't have to be a Medicaid person, but if the facility accepts Medicaid at all, then the individual admitting there must have a level 1 PASS-R screening done. Everybody. They have the level 1. If there's no indication that they have any mental health or intellectual disability issues, then you get a negative result on your level 1 and you're ready to admit. That level 1 the nursing facility needs that information and then they're ready for admission. If there's anything that triggers that they may have a mental health or intellectual disability, the Ascend clinical reviewer is going to ask you for more documentation, do what they call a 1.5 review to get some additional info. They'll help you they will make the determination whether a level 2 is triggered. If a level 2 is triggered, then you make the referral to the appropriate level 2 entity, and Ascend will help direct you and provide the contact information. The Ascend system is not going to make that contact for you, but the contact information will be handy to you right there in the system so that you can get the level 2 ordered. Whoever it is that's doing the level 2 will finish that and return it to whoever requested it of them. And that individual will put it back into the Ascend system so that the nursing facility will be able to see that you did a level 1, it triggered a level 2, you have the level 2, and it says you can go ahead and admit under whatever other specifications they may have, short-term or that there's specialized services that are needed. All of that information would be part of that so that the nursing facility knows what obligations they have upon admission. Anybody who triggers a level 2 and anybody who is a Medicaid recipient then also has to have a level of care assessment done. So you've got the PASS-R piece that's about the level 1 and the level 2, and then you've got level of care assessments that need to be done on your level 2 people and also on any Medicaid recipient because it's a condition of Medicaid reimbursement for nursing facility care. So hopefully I hit kind of all the pieces on there. And again, there's some pretty good diagrams and handouts on the Ascend page that kind of walk through those different scenarios and what happens in each case. So I think you'll find those useful, but hopefully that was a good kind of overview of that. Do patients have the right to bypass PASS? No, they don't. PASS is the current Indiana pre-admission screening process. You'll see it called PASS. You'll see it called IPASS. It's Indiana's pre-admission screening process. That statute, which talks about people waiving their participation in PASS under penalty of no Medicaid payment for a year, all of that goes away midnight June 30th. And so there is no IPASS system. What we're left with is the federal regulations around PASS-R. And individuals cannot waive that level 1 screening. If they want to go to a nursing facility, again, a facility that accepts any kind of Medicaid, even if that individual isn't Medicaid, they cannot go there without participating in the level 1 screening. So they simply cannot be admitted. There is no waiver or penalty period to be done. The nursing facility cannot accept them for admission, regardless of payer source. Oh, well, there's a couple suggestions here. Okay, duly noted. Someone has noted they were able to find the level 1 form on our webpage under the PASS-R announcements towards the bottom of the screen. Great, thanks. I think I actually got through all of the questions, and it is exactly 4 o'clock. That's got to be a minor miracle of some kind. So I appreciate it. I see a lot of people have stuck with us all the way through this. I really appreciate that. We will look forward to doing this again on Monday afternoon from 1 to 3. You're certainly welcome to join us again if you want to, but again, it will be the exact same presentation that we did today. Naturally, we'll get some different questions, but we are going to capture all of these questions and the answers as well, and they'll all be shared on our website as well as Ascend, so you won't miss anything. Don't feel you have to sit through this show again on Monday, and hopefully we'll have room for some additional people to participate on Monday's session as well. And then we'll repeat it again Thursday, June 16th from 10 to noon. So there's 2 more opportunities to hear about this, as well as the resources that are continuing to add to the websites, both the Ascend address and our address. And we've provided you with the PASS-R at fssa.in.gov email address, where we'll be happy to take your questions. Be patient with us for a while as we gear up our capacity to deal with those, but we'll sure try to do next day, 2-day turnarounds at a minimum on those questions. I will share with you also for those that are still left, as everybody kind of signs out, and again, we're very appreciative for you joining us this afternoon. This rollout is scheduled for 7/1. We are very aware that that is the beginning of a holiday weekend, and we will have people monitoring that email address over the holiday weekend. So if you have questions that we can answer and help with, and some of it may be limited by it being the weekend, but if we have things that we can answer or direct you to the appropriate resources on, we will have people staffing that email box during that weekend. So just be aware that that will be a resource available to you. So Roxanne, if you're still on, thanks again for your help today, and everyone have a good afternoon. Mm-hmm.